Today I'll be presenting a topic case for the retina on fire. So this case is a research and kid, 7 years another hospital, then where he was treated, and then for the eye was commenced, the treatment was commenced in So his short presenting illness, he has right eye movement of vision. Vision was further onset for the past 3 months and then become progressive. His paleness is associated with floaters, no eye redness, no discharge, and no similar episode before. For the past medical and surgical history, he has a stroke seizure when he was an infant, and that led to mild and mentally challenged condition. He has quite older, no history of violent behavior, no physical histories, and no immune allergy. So he was diagnosed with AIDS in April 2006 and on heart since then. So his latest profile was 19. His normal weight is 500 to 1,500. He is staying with friends and working in JB in a handphone shop until his private illness. He has a male partner. For the past hospital history, the claim has a good vision previously, no previous history of ocular surgery, no previous history of ocular trauma, and no prior follow-up for any of the diseases. For the social history, he now lives with parents and siblings, currently unemployed. He has a good social support from 2 of his sisters. He denies any high-risk behavior like RVD, but however, he was in homosexual relationship with while working JB and handphone shop. He is a smoker and an alcoholic. For the distinct symptom, he has dizziness, previous one, associated with lethargy, nausea, loss of appetite, diarrhea, weight loss, and insomnia. As for the summary, he is a 56-year-old man with newly diagnosed Wathiwah disease, resulted with progressive painless vein of vision in right eye, associated with floaters for days. He has severe immunocompromised with a CD4 count of 90 and had recently commenced highly active anti-Juen therapy and ocular therapy at the end of April 2036. He also complained of systemic symptom of dizziness, lethargy, diarrhea, anorexia, and weight loss. For the physical examination, Jesus is full, but he appears weak and lethargic. BP is 105 over 65, heart rate is 100 beats per minute. Temperature is 6.6 degrees Celsius. His humidity is 100% in the air, and electricity is 7 millimole per liter. His lung is clear, CBS is 1H2, abdomen is soft, no abdominopathy, no skin rash, normal thrush, and no palpable lymph node. For the eye examination, his visual acuity on the right eye is 660, in whole is 624. Retina is present on both eye, no RVD on both eye. Tonometry in triangular pressure is 10 on the right and left is 8. Eyelid is clear on both eye. Conjunctiva is white, cornea is clear. And then for the antechamber, there's the 6 deep no cell iron seen with the left eye. Ventral vitreous also not present. Iris and pupil, iris normal, pupil round and red tip. Lens is clear on both eye. Basically, for the anterior segment of the eye, this examination is unremarkable. And we go to the fundus emission on the right eye. So in this picture, you can see that 2 strips of retinal hemorrhage, about 1 diameter from the optic piece and the nasal aspect. Retinitis seen and perivascular sheathing noted at distal vessel of nasal and temporal aspect. No discerning. So we can see that there's perivascular sheathing at the periphery, and here is a retinal hemorrhage near the optic disc. There's no disc swelling. So this is a close-up picture of the fundus. You can see there's a white at the periphery, some of the retinitis. So it's like the streak of fire here and on the retina. So we go peripherally toward the on the right eye towards small periphery. You can see that here the appearance is consistent with hemorrhagic retinitis and vasculitis adjacent to the nasal to the right optic disc. So this is the optic disc. So the hemorrhage is appear here. So about 1 diameter from the optic disc. So this on the left side is a normal fundus. We can compare that at the periphery of the patient with the retinitis, it appear whitish grayish as compared to the normal eye. Is normal fundus is clearer view. So this one on the left eye is not as bad as the right eye. The left eye doesn't have the retinal hemorrhages, but at the periphery we can see there's still a perivascular sheathing. If you zoom in the periphery, there's a perivascular sheathing as well. This is the optical coherence tomography, or OCT. Fluid collection at the fovea, compared to the left eye is like so. There's a fluid collection at the fovea. We give the patient a diclofenac, and after 1 week we repeated the OCT. We notice that the fluid is improving. It's somewhat is resolved compared to the first one, and then this one there's no more fluid at the fovea. As for the left eye is normal. Now intraretinal fluid or cystoscopic macular edema-C. So as for our diagnosis, currently is right eye viral retinitis, most likely CMV, and others can be related to herpes zoster, chickenpox, or herpes simplex. And as for the diagnosis, the patient has a clinical picture of hemorrhagic retinitis with vasculitis, and here also RVD with immunocompromise. So as for our zone, related to the how we classify the zone for the retinitis. So this is zone 1. This is our most important zone because posterior pole. So zone 1 is circle or radius of about 1,500 micrometer surrounding the optic disc, and then about 3,000 kilometer, about 3 diameter around the fovea. So this is the posterior zone, the most important zone, and it can affect the vision. And then we go to the second zone. The second zone is suspends are outward from the edge of zone 1 and up to the anterior margin of the rotic veins. This is mid-periphery. Then as for the zone 3 is far periphery. It's extending towards from the zone 2 and up to the oral serrata. So this patient, because of the hemorrhage, is very near to the optic disc, as you remember. So he is in zone 1. So for the investigation, his CD4 count is 90, Dr. White is 4.7, hemoglobin is 12.5, platelet is 395. Renal profile is normal. His viral load initially when he was first presented is 100,000 to 200. But then we started the treatment and then it came down to 54 copies of viral load. Toxoplasma gondii and IgG negative. Patient CSF versus PCR is positive, but biopsy non-reactive. Cryptococcus EG antibody is non-reactive. CMV PCR detected. Procalcitonin is low, is less than 0.1. Blood culture for aerobic and anaerobic is no growth. Blood culture for the fungal no growth as well. Blood TB culture no growth. Urine CNS is no growth. But in the stool culture we got microsporosis. EEG is done, it's normal. EDRL for this patient is not detected. So for the imaging, chest X-ray is clear, but he did an MRI in the private center, so we don't have the feeling here, but we just have the report. We reported as thin periventricular enhancement with corresponding hyperintensity in flight sequence may represent vasculitis. Lesion in both frontal and left parietal of lobes may be ischemic in nature. Then he has a left temporal arachnosis as well. Then he went to treatment in HSI on the 3rd of April. They did CT scan there as well, but we don't have the digitalized view yet. So he reported as having prominent left anterior temporal extra exit space with less effect into adjacent temporal lobe, but no intercranial hemorrhage. So after he started on the 2 weeks of aceclidine, and then patient received treatment from there, we repeated the CT brain. There's no more Mae-Lyn shift, no mass effect, no focal enhancing brain parenchymal lesion. So this is actually the scan from our center, but this, during the scan, everything is already normalized. There's no Mae-Lyn shift, there's no enhancing vision. no ICP as well. So, as a full diagnosis, patient will diagnosed as having advanced retroviral disease with HSP encephalitis, right eyes encephalitis, and macrosporidiosis. So, as for the management, we plan the patient for intravitreal injection of decyclovir twice weekly for 2 weeks. And then, as for the medical side, we started on IV decyclovir, and we co-manage this with the medical team, infectious disease, and neurology. So, as for the intravitreal injection, it's actually a procedure to deliver the drugs into the vitreous via pars plana. It is done in our clinic setting under local anesthesia, and it's about 5-minute procedure. So, when the drug is injected into the posterior segment through the pars plana, so that we can reach the posterior segment better. So, and then we have actually for the HSP encephalitis, started on IV encephalitis 100 mg TDS. We completed this for 21 weeks. And this patient have a temperature spike during admission, so he is on IV Azeanti for the SGPIV. And as for the methods for this, it is on TAP albendazole, 1 tablet OD, and TAP between 2 taps OD for the PCP prophylaxis. So, this is the progress for the patient after receiving about 12 doses of IV decyclovir injection. So, this one, we see that pre-injected decyclovir injection the motion, okay. So then about then after 12 injection, the hemorrhage improve, it become more contracted, and then perivascular shielding also improving at the periphery, and as the left eye is not progressive. So currently, patient receiving weekly maintenance of right eye intravitreal injections of decyclovir. And he also on TAP albendazole and MGOD. And we plan to repeat the CD4 count, and then viral load, and then KIV to stop when the CD4 is more than 100 or many times. So as this picture, it's like retina is on fire, it's every retinitis, and we need medical emergency, and we need to treat them. With that, I thank you.
Thank you, Dr. Anis, for your interesting presentation. Now we know what the patient is facing. Immunocompromised patient with xanthorhabditis have a threatening of his side, and also the neurological involvement. Now I would like to invite Dr. Najma Kori, our infectious disease consultant. She will talk about the viral eye disease and advanced HIV. And this will help us to understand better the pathology behind the retinitis. The floor is yours.
Assalamualaikum, good morning to everyone, students and lecturers. Thank you, Fakulti, for inviting me to give an overview on how HIV disease may affect the eye. So we all know what does HIV do. HIV is a virus, and how does it affect people is that by killing off their immune system, calling the CD4. And the lower the CD4 counts, meaning that the more immunocompromised person will be. We all know that right now. So this study, so why does it matter? Okay, this is one way to prove. In this study done in India, they found that 70 to 75% of patients with HIV at some point will develop ocular manifestations. Okay? And in their study, they found 40% of their HIV patients, despite already on heart, within 1 year, can still develop ocular manifestation. And as you can see here, although the CD4 is more than 500, 8% of them still have ocular disease. So it does matter, okay? And the key discriminator is your CD4 counts. The lower it is, the more severe it becomes. Okay? Diagram to show you how does it affect. So when you have HIV, you just get infected with HIV. What happens in the early stage, which is this acute seroconversion stage, your CD4, okay? All normal people, all healthy patients without HIV, you will have a CD4 of more than 500. Okay? Let's take it at 1,000. So when you get infected, it will drop acutely within the acute seroconversion state. And during the acute convulsion state, you will have some viral-like illnesses. You may be asymptomatic, but some will develop some symptoms that always will be mistaken as dengue. Okay, they will have fever, body ache, a little bit of lymph nodes, with or without lymph nodes, and also retroorbital pain. So that's the initial part. But as HIV goes on into the clinical latency period, alright, early on, they will start having symptoms. And this is when the CD4 is still okay, above 500. They have dry eye symptoms, they have vasculitic features, but more or less, they are asymptomatic at this stage. And then, of course, become chronic. The longer it is, the CD4 drops further, and the diseases start to come. The more opportunistic infections, the scary diseases, herpes zoster, as you have reactivation of your varicella, your molluscum, and so on and so forth. And the last bit was when you've gone into AIDS state, which is CD4 less than 200, and more nasty things starts to come and invade your eye. Okay, similar diagram. Right. So how does it affect? It can affect in both ways. Okay, infective or non-infective. Alright, we are more interested in infective, obviously, because we're from infectious disease. And even in infective causes, there are multiple. It's not just one organism, So ID is a buffet of organisms, and this is what we have to deal with every day, and then we have to pick and play which organisms we're dealing with at the moment. And as the first presenter has mentioned, this patient has SSB and encephalitis at the same time. So is it the same virus that affects the eye, or is it completely different virus? Because it's proven through the CMV PCR and also HSV PCR as well. Okay, just to give my life more difficult. Yeah. So non-infectious causes could be drug related. Okay, it could be the antiviral itself can affect the eye, but more common ones will come to talk that we always give to our TB patients. Okay, you all know this, and the students must know this because us in the exam, you must screen the patient with TB or TB treatment because the ectopical can cause osteoarthritis. That's the commonest one. So tumor related will be like lymphoma, Kaposi sarcoma, and so on and so forth. Alright, so how does bacteria? The commonest one is syphilis. Okay, HIV, very much related. So every HIV patient, with or without symptoms, must be screened for syphilis. And if they have syphilis, you have to exclude ocular syphilis. Yeah? And then the common ones, which is staph and strep infection, it can cause your retroorbital cellulitis and so on. And you have your TB of the eye, and you can have non-TB as well, like your MAC. The common ones are your Mycobacterium avium complex. Again, there's also fungal, your candida, if the patient develops candidemia, not common, but if they have long catheters and all that, while in the ward, they can have candidemia, and candida, you definitely, even in a non-HIV patient, candidemia must be sent to ophthalmology to screen for the eye, because they can develop candida endophthalmitis, and this risk is higher in HIV patients. And then you have other fungals, the dimorphic fungi, mostly a dimorphic fungi, histoplasma. And if somebody has histoplasma, always think of the twin brother, and that is your penicillium. Okay, the twin brother to your histoplasma. And then you have your sporotrichosis and your parasitic infection as well, which is toxo, which is also common in HIV patient. Alright. So let's move on to the main topic of the day, which is how does the viral infection causes eye, HIV disease causes eye, HIV in HIV patient lah. So viruses are nastier, to be honest, and so many of them. Okay, these are the sort of like the common ones. Right. And the typical symptoms would be your eye pain, red eye, photophobia. So you have to ask this history. So when you clear HIV patients, even though patient has no symptoms, you need to ask. You have to exclude the relevant negatives. Okay. So it always starts from top to bottom. Patients usually come, by the time they come, they have AIDS. They come with constitutional symptoms only. Most of the time, they just have constitutional lethargy, a little bit of fever here and there for 2 months. But you still have to ask everything. Do they have dysphagia? Do they have headache? Do they have seizure at home? Do they have, memory forgetfulness? Because that is a sign of osteoporosis. So you go from top to bottom. You go from the, and then what about the eye? Do you have any eye vision, eye disease, floaters? And then you go to the mouth, dysphagia, oral, white thing in the mouth, because it can be herpes simplex, it can have blisters and whatnot, it can have ulcers. And then you go down to your CBS, your respiratory symptoms, and so on and so forth, all the way to the skin. So that's why in the history that we presented just now, the physical examination, you have to look at the skin, you have to ask the joint, ear symptoms, all these things have to go up. very lengthy history now. So first, virus that we're going to talk about is the herpes zoster. Herpes zoster is because of the reactivation in varicella zoster, known as the chickenpox. It's affecting 5 to 15% of HIV patients, right? And then it comes as a rash. But before rash appears, in the prodromal period, it has a little bit of a skin pain because it affects the scalp as well, the ophthalmologic division of your trigeminal nerve, and that includes your scalp and all the way behind the ear and a little bit of a into your cheek. So patient can say they have headache, and that sometimes will lead us to other investigations until the lesion appears and is maculopapular vesicular rash in the upper eyelid, and it penetrates the eye because trigeminal also supply your sclera. Remember, you do the testing, you see whether the patient can blink or not in your examination, neurologic examination. So that's how they can inside there, then it goes affect the whole eyeball, and with or without cranial nerve involvement lah. So there you go. This is orang putih lah, right? So what do? We give them acyclovir, okay, high dose, then followed by oral acyclovir. So maintenance dose. This is about 7 to 14 days. You can go on to 3 weeks at least. And the next one is your molluscum contagiosum. Molluscum also come in as vesicles. The thing about molluscum typically affect children more than adults, okay? And the lesion is caused by the pox virus. The thing is, and people ask, is it still common? It does in children. In adults, because molluscum and thalaromyces, your penicillosis, is very difficult to differentiate. It has umbilicated papule, okay? In exam, when we ask, the word umbilicated must come out. Umbilicated, it's a pinpoint there in the papules. So that gives us a clue, but the problem is, thalaromyces also likes to start from the face, around the eyes, and then it spreads down, okay? So that's why we also include our dermatology colleagues and see whether they can take a biopsy. And because the treatment is different between molluscum versus thalaromyces. Because thalaromyces, you need to give antifungal therapy. Okay. So this is how it looks like. Okay. This is the not so severe lesion, yeah. Sikit je. And then this one, it can affect your sclera as well. So what is the treatment? With molluscum, you just leave it alone. Right? Once you start hard, the lesion will go away by itself. So you tell the patient, don't worry, you're going to get back your good look, because most of our patients are handsome. So you're going to be handsome again, don't worry, this one will go away. All right? Once you start hard, your CD4 recovers, your immune system recovers, the thing will go away. But sometimes we do refer to dermatology, or ophthalmology for surgery because if it's extensive or because it's cosmetically not nice lah, tak cantik. Okay, you still have to do some excision or cryotherapy and stuff, right? So how about varicella zoster and HSV? Funnily enough, although herpes zoster is reactivated by varicella, but varicella on its own primary lesion is different from your herpes zoster. So the presentation of primary varicella is more typical of HSV. So these two you can't differentiate, but normally, varicella zoster, you will have other lesion as well. You will have the skin lesion also, and it's affect your retina in a way that acute retinal necrosis or PON. Okay, so again, we are ID, we like this kind of words. So progressive outer retinal necrosis. Treatment is the same. You give acyclovir, local antiviral, depending on ophthalmology, and it will be hard. Always hard, yeah. Remember that. Kaposi sarcoma. Okay, Kaposi sarcoma is a vascular tumor. Okay, vascular tumor caused by human herpes virus 8. All right, so it's gonna affect your eye, conjunctiva, eyelid, more of anterior chamber. Correct me if I'm wrong. Okay, and it can also affect other organs. Most of the time, Kaposi sarcoma is a diagnosis of exclusion. All right, because the treatment, again, because it's a tumor, the treatment is chemotherapy agent. So you have to be really sure before you decide that this is Kaposi sarcoma. Okay, so I'm just going to pretend as if I know what I'm looking at, but this is how it looks lah. Okay, so most of the time we just believe whatever that ophthalmology say. They say this is a finding typical of this. And then we will relate clinically on the investigation that we have when we screen the patient. All right? So sometimes the diagnosis is made by ophthalmology and then they refer to us. Sometimes we make the diagnosis of HIV and then we send to them to screen the eye. Okay, similarly,
What is this? Anyway, so treatment is again heart and eventually is radiotherapy. Okay, now this is like the highlights of the talk. I'm going to talk about the CMV, which is the king of all HIV eye disease. Yeah, and remember our patient CD4 is 19 and viral load there is not 500 lah. When I was doing this, I forgot what's the viral load. Thank you for reminding me. It's about 100,000, but again 100,000 per ml of blood. So we have 5 liters of blood. So there's a lot of virus going around in the body, and the CD4 is only 19. Okay, and so CMV is the most common opportunistic ocular infection, and the lower your CD4, the higher likelihood of you getting CMV, and happens in the untreated HIV or in the patient who default treatment and therefore they relapse. They relapse HIV, and typical symptoms would be floaters. The thing is, sometimes patients don't know how to describe floaters. Like this patient, they say it's black spots. So that's how we agak-agak lah, or maybe this is CMV retinitis. Then that's when we refer to ophthalmology. And then it's painless, okay? And because it's painless, patients sometimes don't complain. And the thing is, it's continue to progress. If you don't do anything, it progresses very rapidly and eventually will cause blindness. Despite you have started your heart and all that. If you refer late, if the patient receive late treatment, patient will eventually lose their vision. So how frequent is this? It's about 44% of patients before heart era. Okay, ever since we introduced heart, there's so much reduction in the CMV retinitis cases. So the benchmark is always CMV antiviral treatment plus HIV antiviral, and therefore it will improve survival at the same time reduce vision loss in patients living with HIV. So what happens if we do not treat it? Okay, patient will end up with retinal necrosis and eventually irreversible blindness. All right. We have a case where patient went to a lot of private hospitals, not declaring that he has HIV, because then he won't be able to pay because insurance will decline the payment. So they didn't declare he has HIV, and then these eye symptoms and the brain system was going around for quite some time until he actually lost his vision. And that's the time when he comes to neurology here and diagnosed the HIV. Too late for the patient. Patient now is our patient, but it's already blind bilaterally. So remember this, I've written it in red so that everyone remember every patient with visual symptoms, CD4 less than 100, is CMV retinitis until proven otherwise. Okay, even in asymptomatic patient, you have to rule out CMV. What more patients who have symptoms, yeah? So how do we diagnose? It's mostly clinical. So again, like I said, we believe whatever our ophthalm friend said, oh, this is CMV, yes, okay, then we treat. All right? Because it's very difficult to diagnose. There is no test. Okay? So although this patient's CMV PCR is detected, but it's serum. So it actually is not sensitive, it's not specific. You can have CMV PCR detected without CMV retinitis, and you can have CMV retinitis without your serum CMV PCR detected. Know what I mean? Okay. Even more, less useful is your serology, doesn't help at all, or if you're doing CMV viral detection assay. So it's all clinical. So if the moment ophthalmologist say, oh, okay, this is CMV, then we treat. And this picture always come out in the exam. This picture, and you're supposed to describe. Used to be scrambled eggs and tomato ketchup or pizza pie, which we still accept, but the newer terminology for this is bushfire pattern. So that's why Retina on fire, yeah. So this is orange, the orang putih country where the leaves are all in orange color and you have bushfire in yellow color. So treatment is CMV, IV or oral. If patient is well, the best is to give oral vancomycin because oral Valgan is as good as your IV. Okay? But if the patient's in the ward, you worry about the gut absorption, then you give IV. All right? And induction phase, 2 to 3 weeks, followed by maintenance phase. When to give intravitreal, I always leave it to ophthalmology. Usually they know, oh, this is category 2, category 3 or whatever. You know, the more severe it is, definitely they need local. Okay? And how long do you treat it? Induction for 3 weeks, followed by maintenance. Everything in HIV patient maintenance is until CD4 more than 200. Here it wrote as 100. But for easy to remember in exam, you just write more than 200 is fine. Okay? Because some we give until 200, but CMV is actually enough with 100 times 2 or CD4 more than 100 for more than 3 months. It takes very long time for CD4 to recover. It takes more than a year. So this patient, as you can see, the moment we start hard, the viral load from 100,000 become 58 within 2 months. Okay, but CD4 will take much longer. So the treatment maintenance phase for this patient is going to take about a year. Okay, and Valgan is not cheap. Yeah? All right. Now, so if you can inject, okay, let's say the lesion is mild, so the ophthalm is going to give IVT only. So why do we still need to give systemic? Do we still need to give Valgan or ganciclovir? Yes. Yes, it's proven in multiple studies, you need to give the systemic therapy to prevent the lesion to spread to the other eye. You want to protect the other eye from also getting blindness. So must give, always give systemic therapy. Okay, so when ophthalm refer to you, don't be angry lah. They say, because it's indicated, okay, you need to give systemic. They can give either IVT, but systemic treatment is under medical, yeah? So, and then if you don't treat, you don't give systemic, there's a chance that it also goes spread to other organs as well. So you can get CMV colitis, you can get CMV esophagitis, CMV pneumonitis, and so on. So that can cause mortality. Am I?
Excuse me,
yes.
You have one more
Last
minute.
one. Okay, this is the last slide. So I just want MOs to know that there is an entity called IRU, and it is like our iris. So when you treat, there is a period of improvement before it gets bad again. So in this situation, okay, the treatment is again ophthalmology treatment, which is injection steroids. That's it. I'm happy to take questions later on. Yeah, sorry for the extra time.
Thank you so much, Dr. Najma. Very excellent lecture. So we'll continue. I would like to invite Dr. Wathiwah. She will take us through the parasitic infection in RVD.
Thank you, Dr. Yanti. Assalamualaikum and a very good morning. My name is Wathiwah. Today, from the Department of Parasitology. Today, I will share the parasitologist's perspective for this case with a presentation entitled Parasite in RVD. I will go very fast. So for this patient, today CPC highlighted the ophthalmic emergency, but we looked at the initial presenting illness of this patient. Patient actually come with the diarrhea and reduced consciousness. He was started with investigation revealed he had low CD4 count and started with heart. And so for the parasitologist, the simple question is what organism that can cause this clinical manifestation. So the diarrhea is actually affects 40 to 80% of RVD patient not on antiretroviral disease, antiretroviral therapy. So the culprit, the usual suspect, is this four: microsporidiasis caused by enterocytozoon in Bernisi, encephalitozoon intestinalis or caniculi, or the second one, cryptosporidiosis caused by Cryptosporidium parvum or hominis, cystoisosporiasis caused by Itospora belli, or previously known as Isospora belli. All these three is actually protozoan, very small one. And the strongyloidiasis, the helminth. We can include in this RVD patient, Strongyloides tocoralis. This is one of the most common organism. The others can cause, but this four is the most common one. So based on these four, the presentation is quite similar. They can have diarrhea. All of these three can cause watery diarrhea, which is patient can come with protracted diarrhea, chronic diarrhea up to 4 weeks, or strongyloides, diarrhea, and abdominal pain. And all of it, the transmission is from fecal oral route, which contaminated food or water, environmental exposure, and also unsafe sex. And with the RVD patient, the CD4 count is usually associated with low CD4 count, usually less than 100 in microsporidiosis and cryptosporidiosis, less than 200 in cystoisosporiasis, but varies in strongyloidiasis. But even though the CD4 varies, in the RVD, if left untreated disseminated strongyloidiasis, the mortality count can up to 90% if left untreated, because disseminated strongyloidiasis, it can go to all over the organs, for example, the brain, the ocular, because of the larva can go up to the the other organ. And the management is different. For the disseminated strongyloidosis, you must treat with ivermectin. And the other organism also have the management. You can treat with albendazole, nitazoxanide, or Bactrims. And the other disease, extraintestinal, was very rare. And in the diagnostic approach, for the diarrhea, you must get the stool specimen, where we will do in the lab direct wet mount examination, where we do look the detection of microorganism under microscopy, and some of the sample we proceed with further staining. For example, gram chromatochrinion. In this patient, this is the gram chromatochrinion staining of the fecal sample. It reveals there is a numerous ovoid organism with the thick cyst wall and belt-like stripe, which is an horizontal stripe at the center, like this one. This is under GCK. And numerous, it revealed the patient have heavy intestinal microsporidiosis. If want to proceed with the species detection, can do the molecular confirmation by polymerase chain reaction or sequencing. Microsporidiosis relatively high in immunocompromised, actually nearly 30%, and disseminated microsporidiosis among HIV about 7%. And back to our case, this patient was treated with albendazole and resolved after 5 days. That's very good. And the patient was continued with the albendazole for 21 days, and he was counseled with the personal hygiene and safe food practice and sanitation measures. So how about the reduced consciousness? Could a parasite explain the reduced consciousness? The patient has clinical manifestation of CNS involvement and history of childhood seizures, and also history of cat ownerships. So toxoplasma encephalitis can be one of the differential diagnoses. Disseminated microsporidiosis because of the presence of fecal in the specimen. Disseminated strongyloidosis, but less likely because not found in the stool specimen or and other clinical manifestation. So the first one is toxoplasma enceph. In this patient, in RVD patient, it is most common CNS pathology caused by parasite, and the prevalence is about 10 to 40%. It occurs because reactivation of latent organism. This is actually the bradyzoid, tissue cyst in the brain. When the CD4 count fall, it will rupture and cause pathology in RVD patient. And usually the confirmatory diagnosis, definitive diagnosis is very invasive, require the tissue brain. But classically, we will do the presumptive diagnosis based on the clinical manifestation, neuroimaging where there is a presence of multiple ring-enhancing lesion, and also toxoplasma serology. And back to our case, he had serology, toxoplasma IgG and IgM was negative. And CT brain was no enhancing brain parenchymal lesion, and cerebral toxoplasmosis was definitely unsupported. How about in the eye? Can parasite cause auricular manifestation? So for this patient, there's two diagnoses: toxoplasma retinochoroiditis or microsporidial choroidoconjunctivitis. But back to our case, the toxoplasma is negative, and the ophthalmic findings were less suggestive of parasitic disease. So the take-home message: diarrhea in RVD always prompt consideration of opportunistic parasitic infection, and patient with neurological symptoms requires exclusion of cerebral toxoplasmosis, and multiple pathogens in RVD may coexist. Early recognition can significantly improve patient outcome. Thank you for your attention. I would like to highlight our department workshop, intestinal workshop, at the end of this month. If anyone's, you can share with your friends or can attend with the workshop. Thank you.
Thank you, Dr. Wathika. Next, I will invite Dr. Tan Juen Kiem, our internist and neurology fellow. He will guide us to the opportunistic infection of CNS in
Okay,
RVD.
thank you. Sorry, I think we are running out of time. If I don't speed up, then Prof. Mae-Lyn don't have to take the stage. So So thank you very much. Good morning to everyone. My name is JK. I'm representing the neurology unit. So thanks to Optal team for the invite. So basically, my task is actually quite a broad topic about talking about the opportunistic infections regarding the CNS, which a RVD patient could suffer from. Of course, I'm not so crazy to think I can finish the topic in 8 minutes, so I'll just focus on a few things which I feel is important, namely the clinical approach of how you will tackle a disease and also some important diseases which may come up for your exam as well in real life. So as Dr. Najma said, there's a large spectrum and a buffet of pathogens which ID people will have to face, namely bacteria, fungi, viruses, and parasites. But how they actually affect humans are by 3 mechanisms, mainly direct tissue invasion through the brain parenchyma of the meninges itself, through neurotoxin. For good example would be a botulinum toxin, and also immune response. So in clinical approach, usually we pay attention to several topics. One, namely, is the time course, the symptoms you will see, some clinical context relevant for certain pathogens, and how, of course, neurology people will always like the whole purpose about history taking, the whole purpose about clinical examination is to know where the disease is or to localize it so that you know what investigations to order. You know, you don't carry a shotgun and just shoot randomly so that you try to hit something. So when you talk about time course, basically, we usually classify them to acute and subacute. Some diseases will have a very slow, insidious progression. Some will be very fast. So acute generally means the progression happens within a few days, within a few hours, and subacute usually up to 4 weeks onwards. You usually see this in other pathogens like fungal and mycobacteriums, but viruses and bacteria tend to usually cause disease earlier. And the associated symptoms for neurology side is mainly headache, signs and symptoms of raised ICP, for example, projectile vomiting, fever, constitutional symptoms like weight loss, and of course, some other signs you might want to look for, in particularly from head to toe, as Dr. Najma said, is oral thrush from the top. So those are usually commonly seen in patients with CD4 is less than 200 already. Some skin changes, specifically those which you will see dermatomal distribution like in shingles, and also the purpurate rashes you will see in the meningococcus. And some eye findings, agar-Robertson pupil, which is associated with syphilis, retinitis as well, the pizza pie appearance or the bushfire appearance. You also tend to look for systemic symptoms, lungs. Most of the time, patients may come with pulmonary TB with extrapulmonary manifestation by virtue of having TB meningitis. CVS, GI tract as well, and our patients did have microsporidium. Genitourinary by virtue of patient having syphilis, so chancre, HSV, and CMV. And it's always very important to remember that you always have to have a very high index of suspicion among them, because these people, they may not mount an immune response, so they may not come with fever at all. Okay, so you must be very acute, and your clinical acumen, you have to think about any possible reason the patient may come in relatively lethargic. In terms of clinical context, some patients mainly have already started some form of treatment, as ID team have mentioned before. Patients can come with some immune reconstitution syndrome, so they can actually come with fever, some enlarged lymph node, and sometimes in MRI images, if they were already treated, for example, toxo or TB, if you start hard quite early, the patient actually might have a paradoxical worsening of the clinical signs as well. Past head trauma or neurosurgery, patients may have risk of ventriculitis through CSF leak, whether the patient has got any IVD use, and travel history, because as you can see from here, if patient has gone to specific regions, there may be some endemicity, namely in our region, as you can see, cryptococcal, cerebral toxo, TBM, JE, these are the common questions you also get for exam, namely because they're endemic here. Nobody's going to ask you about Chagas disease. If they ask, maybe I also cannot answer. Okay, so localization, meningitis is namely the inflammation of the meninges. So patients generally come with fever, neck stiffness, and also headache. Well, encephalitis is just the inflammation of the brain parenchyma. By virtue of them having more focal neurological signs, they become with seizures, altered mental status. More focal lesions, for example, if they have got a cerebral abscess, or if they got a tuberculoma affecting one part of their brain. And this can also cause cranial neuropathy, myelopathy, peripheral neuropathy. And symptoms usually depend based on where it is. So if they got some myelopathy, they may have some severe back pain. Okay, they may have bilateral lower motor neuron lesions. And the relevant investigation will subsequently be based on what you have gotten from the previous 4 segments. Generally, you would still get a CD4 count for anyone who is RVD positive. And then subsequently, you will send VDRL, VZV, toxo, IgG, etc., depending on what you got from the history. TB workup is usually a must for most patients, regardless, and I think we do it quite routinely, which will involve month-2 testing. We try to get sputum from them as well, send for AFB, direct smear, TB-CNS, and also sometimes TB PCR or gene expert. Do sign cultures and also do some neuroimaging like CT and MRI prior to doing a lumbar puncture, okay? So in exam context, I guess the thing that is in the box is the most important, is one we frequently ask you as well. So do know that opening pressure is usually high in patients with crypt and also tuberculous meningitis compared to a virus, and also the protein will be much higher. So I'll focus on a few diseases. One of it will be tuberculous meningitis. This is more common than people think it is. It does not necessarily have to be from a disseminated disease. It can actually be a primary illness on its own. Presentation-wise, roughly similar from a HIV and non-HIV patient. They usually come with a very insidious and progressive clinical signs or symptoms, mainly same fever, they have mild headache, they have giddiness as well, depending on which part of the brain affected. Some can come with some focal neurological deficits, they can have weakness which looks like a stroke. But eventually what happens if they are untreated, sooner or later they'll develop brainstem dysfunction, and sometimes it's not unusual to see patients with TB meningitis who are bedbound, don't respond to questions and so forth, okay? So for imaging, usually what we're trying to look for is tuberculomas. You can see here in the T2 weighted hyperintensity over the basal ganglia regions and also over the temporal regions. And also some of them actually have hydrocephalus by virtue of the mass effect. Treatment will involve anti-TB and pyridoxine, but steroids is plus minus. Usually in TB meningitis, for our regime, we add steroids, but in the context of a patient with HIV, sometimes it's very difficult to differentiate them from CNS lymphoma. So when you give them steroids, the lymphoma, CNS lymphoma may just disappear, the lesion. That will affect the diagnostic probability. So cryptococcal meningitis is also insidious and progressive. Usually they come with similar symptoms, headache and giddiness, some focal neurological signs. They might have some diplopia and also eventually seizures. For these patients, it's always important to do imaging first. I think for any patient who is HIV positive with a neurological symptom, you should always do imaging first, because when you don't do imaging first, the risk is always, by virtue of them having hydrocephalus, which may be non-communicating, you actually run the risk of doing an LP, and then patient may eventually develop herniation, all right? So usually when you do LP, you want to send encrypt antigen and so India A, and treatment will be amphotericin B and flucytosine. So I'll skip this because I think Dr. Wathiwah has explained this quite nicely, maybe better than me, but I just want to stress the point that these patients, if eventually they develop serum toxoplasma IgG or IgM negative, you should think of an alternative diagnosis. Usually it's a very good negative predictor. And if they do have positivity, you may still need to do further investigation. Treatment usually involves a long course of Bactrim for induction and maintenance. And finally, what our patient has, luckily I put a slide in. Actually, I don't know what the diagnosis until yesterday evening. So herpes simplex virus encephalitis. Actually, HSV1 is the main pathogen for HIV patients, so for general population, but HIV2 is actually quite common in HIV patients, even though it's much lesser percentage, usually only about 10% HSV2 compared to HSV1. So in imaging, they have this very typical, because the the virus usually has this predilection for the limbic system and the temporal area. They usually see a hyperintensity swelling, which may be associated with some hemorrhage on SWE imaging over the temporal region. For these patients, it will be wise to get a CSF analysis. You will expect to do a HSV PCR, which should be positive in your case. And typically in a neuro case, sometimes when they really start having altered mental status, they may have seizures. You see this very typical, previously we call them PLEDs, periodic lateralized epileptiform discharges. Now we call them lateralized periodic discharges. Same thing, different way of saying. You see this on the right side, which is the red color markings. The right side electrodes are usually showing these spikes, sharp and slow waves, compared to the left side, the blue ones, which don't show anything. So that's lateralized to one side. So treatment will require patients to receive IV acyclovir, usually 2 to 3 weeks in total. For severe cases, it's always recommended for 3 weeks. Corticosteroids, they have got conflicting results. Some people say patients do better with corticosteroids. Some say no difference. So we don't encourage it. But what is more important is to start the IV acyclovir as fast as possible, preferably within 48 hours from the disease onset, because the longer you wait, the more inflammation and more scarring can happen to the temporal and also limbic area, and they will eventually develop very bad cognitive issues and also seizures, all right? And this is actually quite common. Actually, up to 70% of patients with HIV suffer some form of sequelae by virtue of these or even some mood disorders. So I'd like to end this by saying a few things. One is please take note of the CD4 count. Even you are going in a long case, you can probably ask the patient. Most of them are very well educated. They know their CD4 count. And when you get the CD4 count, it also gives you some clue about what opportunistic infection the patient may be prone for. You always have to have a high index of suspicion because they may not mount that immune response. And they don't really follow a textbook. My prof always says, Prof Tan always say, disease never follow textbook. So you always have to have an idea that, okay, this might be this 50%, you work up for that, all right? Don't think that it has to fulfill every criteria before you think that it's a diagnosis. Try to do a targeted investigation to minimize delay, and subsequently, if possible, usually in most settings in ID, you usually have to initiate early therapy, because when you don't initiate empirical therapy, usually you wait too long for results to come back and patients will suffer more sequelae later on. All right, with that, thank you very much.
Thank you, Dr. Tan. Now we continue with Prof. Mae-Lyn, our chairperson. She will tie this up together back to the eye. Please, Prof. Mae-Lyn.
Very good morning to everyone. Thank you for coming for the CPC today. And I would like to thank also my medical colleagues for laying such a nice background of the medical aspect of this case that I think I'll just, in the available time given to me, quickly cover and put everything together, the ophthalmology perspective on this, retina on fire. So I think you've seen the summary and you know this is a case of a young man with the RVD, and he has these very interesting symptoms of floaters and blurring of vision, and we know he's got severe immunosuppression as a result of the RVD. So we have seen what are the examination findings in this case, and here we're talking about active CMV retinitis. So let's just analyze the implications of the symptoms of this patient. So what are floaters? Basically, these are an entoptic phenomenon, and I think our postgraduates can relate to this, where the source of this symptom is actually from within the eye itself. This is quite well described from history, and there are other examples as well, and I think you can relate to the fact that understanding that we even have blood vessels in the retina, and sometimes you can actually perceive these, So the source of it is from the eye itself. I don't have time to really take you through the simulator, but basically the simulator was designed to show what floaters are and what you can see when you're experiencing floaters. And basically that these black spots or wavy lines that move around in your vision. They don't stay in one position, and this reflects their position from arising from within the gel, because they actually cast a shadow onto the retina. So this is a very quick algorithm for floaters where you can appreciate that a recent onset probably has a more insidious origin. So our patient only had it for a few days. So you work down the algorithm, you can see recent onset. You've got to consider whether there are any flashes in this case, or whether there's any sort of like a scintillating scotoma. And if the symptom is in one eye or both eyes, in this case it's just one eye, but if it's both eyes, you still have to consider the systemic causes. One eye with light flashes in the periphery makes you think of retina detachment, and you can see that this leads to ophthalmology consult, especially when the symptoms are constant and increasing, as in this patient, right? So you refer. So this is where the red alert comes in, and this is a reminder of the sight-threatening causes. It's very easy to recall that in the vitreous gel here, you could have red blood cells, you could have white blood cells, such as what our patient had, or you could have tumor cells as well. So you can see that undersight or life-threatening would be things such as vitreous hemorrhage, tear, detachment, etc., which also need urgent attention. Some of it can be due to proliferative retinopathy. So in the case of our patient, with the presence of a recent onset, and we have to think of infective causes because of his immunosuppression. You can actually see these cells on the slit lamp. So this is a reflection of where we would consider this an urgent referral. So we can see he has a reduction in vision in addition to his symptom of floaters, but when you do the 2-minute approach, you can't find anything. Remember, the 2-minute approach is meant to allow you to examine and to determine whether this is a media opacity, whether there is a conduction defect or whether it's macular. Now in this patient, it's all normal. And actually when we go back to the OCT, we find that there is an inflammation on the surface here that actually casts that shadow that caused the patient to have the floaters. So always remember that they have altered signs. When they have immunosuppression, they don't really mount a brisk inflammatory response, right? So the eye is white. So you might be fooled to thinking this is not urgent, but not the case in this situation. So already we have gone through this, and basically we know this is in a threatening zone. And this is actually a fulminant type here for the postgraduates here. There are 3 types. And this one is an example of fulminant type. It's really close to the optic disc. If you're not careful, this brush fire will go into the disc. So this is actually a burn and die situation for the retina. Now we managed to treat these patients, and therefore the patient goes into a maintenance phase. The game is not over yet. We still have to play on. We have to ensure that this totally disappears, and we have to wait for immune reconstitution, right? These are other examples which I won't go into. And the other eye, it may be totally asymptomatic, but again, emphasizing that our non-mydriatic fundus photographs do not pick up peripheral lesions, so we can't do with that. And already we've explained why we need to kickstart back the immune system, okay? So this is just a reminder of how the OCT is an investigation, helps us to pick up these subtle signs that cause the poor patient to have floaters and blurred vision, namely the subretinal fluid. So managing the retina and the whole patient has to be a two-phase approach, combining the efforts of both ophthalmology and infectious disease to start the patient first on this induction phase, usually lasting roughly about 14 to 21 days. And the purpose is to halt the viral replication, both in the eye and in other areas. So we base it on lesion location and systemic involvement, starting with our first line, which is the oral valganciclovir, and other options. Okay, we've gone through some of this, and then the patient goes into the maintenance phase, which can last several months, at which point, when do we stop? Basically, the end of the road is once we get these CD4 counts above these levels, but the patient still needs to come back for review. I think we've touched on other effects as well of the treatment, as well as the disease, and we're really working together to address all opportunistic infections in these patients. So these are my take-home messages, basically giving the necessary urgency to floaters of recent onset in immunocompromised patient, not only patient with retroviral disease, but any patient on some form of immunomodulator. The CMV retinitis is essentially the clinical diagnosis we saw with very characteristic features, but we need dilated eye examination because not all the time it starts in the posterior segment, sometimes posterior pole, sometimes you get very peripheral lesions. So we need to treat these so that we can combat the local and also systemic manifestations of the infection. So our treatment principles of CMV retinitis in AIDS hinge on restoring our immune system with HART, reducing the viral load with the injections intravitreally, protecting our fellow eye with the systemic treatments and HART, and then we treat any immune reconstitution inflammation. So you see here with topical steroids or oral steroids or NSAID, depending on severity, and we co-manage with other systems with the physicians. And I think that we need to consider eye screening when patients have low CD4 counts with a low, such as 50 cells per millimeter cube, because they are actually at risk of developing this disease, and not all patients present with the floaters and blurred vision that we know. So these are some references, and we even have a consensus internationally, but still there are controversies with regards to treatment of CMV retinitis. You can contact me for any questions, and very much my appreciation to the excellent team that spoke at today's CPC. Thank you, everyone.
Thank you, Prof. May, for the excellent summary. Now, because we are running out of time, I think we can continue to the final session, which is quiz.